observing the patient during walking, sitting, standing, the way they move their eyes, without even touching the patient. So that, some people are very good at that. But for the sake of discussion, you examine the ears. The other thing you need to look at is eye movements. And actually, when you're looking at the patient, you will be able to figure out if the patient has normal eye movements or not. Sometimes, because they can pay attention to you for pursuit tracking if you're talking to them and maybe kind of moving your head back and forth. You can do that, but we look at the saccades. And the way you, and the other thing is obviously the neck movements, which you can see readily. But for the saccades, the best thing is look to my nose, finger, nose, up and down. That's your saccade test. Pursuit tracking, you can do that. So that's your pursuit tracking. Move your head to the right.
Specific distance for me? How much?
I mean, just like that. Yeah. I mean, if you come close to this, you're going to use the crossing of the medial picture. But that would be fine. 90%. And now just move your head to the right, to the left, down, up. That gives you idea if there is any cervical limitations, right? Okay. Then the next thing you can actually do while if the patient is standing is look at your thumbs like that, right? And just go back and forth like this. And watch the eyes. Watch my eyes. They have to be centered. They're not. They shouldn't be moving, hopefully. Okay? And that's your visual vestibular reflex. Remember that reflex? Visual input, accessory optic tract, inferior olive, cerebellum, up to the vestibular nuclei, inhibiting the activation of the vestibular system. Right? So that's, and then you can do the stepping. Eyes open, closed, and observe if there is any drift back and forth.
If yes, drift to one side, is it that either weakness in this side?
That's a good question. If for example, I'm stepping like that, all right, and then I'm doing this, all right, so I'm drifted to the right side. What is this supposed to mean?
Right hypotenuse. Right.
Can it mean a decreased vestibular function on the right side? Yes, it can. Can it mean that your left side is overactive? Yes, it can. Or what it tells you, normally patients or people would be in the center. And if you drift right or left, then there is an asymmetry in the system. That's all what it's going to tell you. But it's not going to tell you the side of the lesion. And the reason for that is there are two reflexes in the vestibular spinal tract, the medial and the lateral. The medial tracts are actually crossed, and the lateral tracts descend ipsilaterally. So there is a lot of crossover, and you can't use just the direction in which you drift as the side of lesion. It can be one side down or one side up. And that's an important concept. The two sides of the vestibular system put you in the center. Normal, walking, talking, whatever. If one goes down, let's say acute vestibular neuritis, that's going to go down, and the other one is going to push you like that, and you get peritative status to the opposite side. That's a very good point. Explain that.
If we have to see the signal lesion on the right side of the sound and this compensated, you might not have such deviation to the side. Usually the sensitivity of such test means that either one side is down and the other one is down.
الصوت يا دكتور محمد.
Okay, this is a sign of compensation, but the range. Yes. In the range. You will not have sign of decompensation or uncompensation. you have just right caloric weakness and nothing else, this is compensating the peripheral damage. This sign of compensation starts from spontaneous status. Spontaneous status is a sign of acute lesion, definitely, and a sign of deep uncompensation. Positional status is a sign of uncompensation, directional improvement. You will never have directional improvement if you will have a spontaneous status. You will have anything directional. It's actually the spontaneous status. Spontaneous status, that means the beating will be more to one side.
Can I ask about the
Do you want to read the certificate? So, to do the vestibular ocular reflex, this is kind of a little tricky. If you are a busy surgeon and you have a busy clinic, I don't know, you have the system or not. If you don't have a way of taking visual fixation away, the simplest thing is the frontal glasses. If you don't, then I don't think you're going to be able to make any reasonable conclusion about the vestibular ocular reflex. In that case, fine, you can do an ENG. And we're going to come to how much of an ENG testing you need. But if it happens that you have this, so assuming that the patient, you've seen the picture, patient is sitting, or you can actually do it standing too. I mean, but the only thing is, you're not going to be able to adjusting the camera. So you adjust your cameras. And you just watch the eyes for a few seconds. Try not to blink. Ask the patient, try not to blink. Oh my goodness, you've got it on 20. No, you don't have any status. Keep the eyes open. And you observe the status. That's spontaneous status. And then you just hold the head and gently go right. It's the opposite. This is actually one of the issues with this medical system. You noted on my system, when you move the head to the right, the software or the cameras need to be adjusted so that when you move to the right, you got right being nystagmus. Here, you move to the left, you got left being nystagmus.
The eyes always go to the opposite direction.
And then you keep the eyes open.
This is another sign of vestibular decompensation. You have posterior cheek status.
Does it have posterior cheek status? Now, I don't know if there's white here. Can you see the white? So this generate white here. Location. You just, look at my nose, and that you can do the so-called head impulse test. You can do quick to the right, quick to the left, right, left, and there is no post-motion sequence. You cannot really, the only way you can do the fixation suppression